Now, in this part of the chapter, we will be talking about the altered state of consciousness, which can obviously be due to a disease, but it can also be due to things like hypnosis or mind-altering drugs or certain diseases like psychiatric illnesses. And the altered state of consciousness refers to the unusual senses. Sometimes we might be hearing things or seeing things and so on. That's what we mean by altered state of consciousness. Schizophrenia, for example, is a disease where the information is not processed properly in the brain. So there could be things that the patient is experiencing, but they're actually not there. The patient is the only one seeing or hearing these things, the only person that has these thoughts, and the process of hearing or seeing things that are not really there, those are known as hallucinations. The most common kinds of hallucinations are auditory ones. The patient would have these thoughts that maybe they are the chosen one to save the world, or that there is someone, there are aliens that are coming to abduct him. These are known as delusions. So these are thoughts that are only the patient is experiencing, and it is not thoughts of the community. Okay, schizophrenics tend to be on the withdrawal side. They can become emotionally unresponsive, so they don't respond to, like hugs and so on. They're more, they appear to have these cold emotions. They might appear to have inappropriate moods as well. So they could show happiness when they should not, in situations where they should be showing more sympathy maybe. And that again is because their brains are not processing the information as it should be. Okay, they can also sometimes experience abnormal motor behavior. So there are patients that go through catatonic phases, and that means that they pretty much freeze up. Okay, so there's just total immobilization of their skeletal muscles. The symptoms of schizophrenia are very wide, and there's a whole range for each of these different symptoms. Patients do not look like each other whatsoever. Although we're really not sure what the cause of schizophrenia is, but we do know that it might have been due to during brain development, that there was these neurons that were supposed to migrate or mature. They did that in an abnormal fashion. So it might have happened during brain development. One of the hypotheses that are out there is that there is an overactivity of the mesocortical dopamine pathway. So remember we talked about the dopamine pathways, that we had a mesocortical and a mesolimbal. So this overactivity of the mesocortical dopamine pathway has been implicated as a cause leading to schizophrenia. And the research kind of supports that in a way, because when you give these amphetamine-like drugs, okay, it increases the dopamine signals, and that leads to worsening of these symptoms, which means that higher than normal levels of dopamine can actually lead to schizophrenia. And if you give dopamine receptor blockers, that would improve the symptoms. Schizophrenia is common, so it's about 1% of the population above the age of 18. It typically starts to develop and show symptoms usually during the late teens or in the early 20s. And that is usually when the brain development is almost complete. Now for mood disorders, again, everything is a range. Okay, so you don't want to kind of take it as these are all of the symptoms of depression, or these are all of the symptoms of mania. Somebody can have a symptom that points to depression and a mild symptom that maybe points to mania. And so it's very variable. You have to take a very good history from the patient to get everything that's going on. But the mood disorders range from depression to mania. Mania is the opposite of depression. And then there's a bipolar disorder where the patient goes back and forth between depression and mania. So what are the differences between them? So depression is the more common of these three mood disorders. It is the feeling of emptiness or sadness, loss of energy, loss of interest in daily activities. The patient could have anxiety. There could be change in the appetite, change in their sleeping patterns, even thoughts or act of suicide. These are all pointing towards depressive disorders. Mania, on the other hand, is by patients the person would develop these very unusually elevated moods. So they would be happy all the time, hyperactive. They've got what are known as like racing thoughts, where they talk a lot, and what they're saying sometimes doesn't make sense because the thoughts on their head are going really fast and they are trying to express them, so they're not coming out as sensical. A bipolar disorder is, again, a person where they swing between them two. So they've got this depressive episode and then followed by a manic episode and so on. Now, depression again. Okay, depression can be independent, meaning that that's all the patient has. Okay, I don't say that in kind of belittling it, but I'll tell you what it means when I talk about secondary depression. So depression means that this is their primary diagnosis. Okay, so it's independent of other illnesses. Or it can be secondary to another medical disorder. So let's say the patient maybe has arthritis and the arthritic pain is constant and chronic, and that is the cause of their depression. Okay, so again, we've got primary depression or independent depression. And then we've got secondary depression, which would be secondary to another medical disorder. And usually to treat secondary depression, you want to treat the cause of the depression. So treat that first disease, try to treat the arthritis if that's what's causing the depression, control whatever is going on, and that should take care of the secondary depression. Not all the time, but sometimes it does. Depression usually is associated with decreased nerve activity in the anterior part of the limbic system. So remember, we went through the different parts of the limbic system that was scattered throughout the brain. The anterior parts of it is when you've got decrease in the neural activity, especially towards the frontal lobe, that's when depression would occur. The neurotransmitters that have been blamed for depression are norepinephrine, dopamine, serotonin, so a decrease in these. It could be a decrease in dopamine or norepinephrine or serotonin, or a combination of two or three of them. And acetylcholine has also been implicated. And because there's so many different neurotransmitters that are involved, the treatments are very different from one patient to another. So we have these different treatment options. These two right here, the tricyclic antidepressant drugs and the MAO inhibitors, both of these work on increasing the levels of serotonin and or norepinephrine in the synapses. So TCAs, okay, they prevent the serotonin and or norepinephrine reuptake, and that increases their levels in the synapses. MAO inhibitors, on the other hand, they inhibit the monoamine oxidase enzyme that would break down serotonin and norepinephrine. So now that you're not breaking them down anymore, they are going to remain in the synapse a little bit longer. This third one, this is the most commonly kind of medication used for depression. These are known as serotonin specific reuptake inhibitors. So these inhibit the reuptake of serotonin in particular from the synaptic areas. That increases serotonin in the synapses, and the pharmacological ones that are used are known as Prozac, Paxil, and Zoloft. There are alternative therapies, so not everybody responds to these treatments. Okay, and remember we said that depression, there are lots of neurotransmitters involved. There could be different reasons, so it could be primary or secondary to another disease. Most commonly, it would be due to chronic pain. So even if you treat, chronic pain is very hard to treat, but even if you do treat it, well, will that automatically take care of depression? Sometimes it really, most of the time it actually doesn't. And now that they're depressed, they get into this cycle of depression, loss of appetite, loss of weight, or hyper eating and increase of weight. Now their arthritis gets bad, worse because of the obesity. Now they're going again, starting that cycle all over again. They've increased in weight, they gained weight, their arthritis is worse, their pain is worse. Now they're more depressed, and we go in that cycle. Sometimes it's extremely hard to break that cycle. Some patients need to go the extra mile in their treatment, and we've got different options. So one of them, and we no longer use that, it's not really widely used anymore, that is the ECT or electroconvulsive therapy. And the thought behind this is that to give an electrical impulse to the brain, and that would lead to convulsion or seizures in the patient. So you can see why this is no longer being used. The thought is it's kind of like when you restart your computer, okay? Is that making sure that all of the neurotransmitters and everything kind of reboot themselves and get back to normal, or when you restart the router. Okay, so you are basically trying to start everything from scratch. Okay, changing the neurotransmitter levels, changing the sensitivity of the receptors to serotonin and norepinephrine, and hoping that it works. ECT would be done, it had to have more than one session. And again, it is painful. It is not a pleasurable experience, to say the least. So it's not done, it's done on a very, very, very small range right now. It has been replaced with this RTMS, or the repetitive transcranial magnetic stimulation. So the thought is the same. Okay, so again, it's kind of rebooting the brain, restarting it, but instead of using these painful electrical stimuli, we're using magnetic stimulation. So transcranial magnetic stimulation. And you can see here the patient is fully alert. There's no pain involved. And it's the electromagnetic waves that are resetting everything. Now, for bipolar disorder, the term bipolar means that the patient swings between episodes of depression and then episodes of mania, and then they go back to an episode of depression and so on. So we already talked about depression. Let's talk a little bit about mania. And that's where the patient has these abnormally elevated moods. So being in a good mood for one day is definitely not mania. Okay, so but they have these abnormally elevated moods, sometimes even to the point of euphoria, where they're just laughing hysterically, racing thoughts, again, and making them talk. They'll talk very fast, and a lot of the time what they're saying isn't making sense because the thoughts in their head are going much faster than they are coming out. Lots of energy. So sometimes they will come in and family members will say they were up all night vacuuming the whole house, doing the laundry throughout the night, and because of all of that excessive energy they're experiencing. They're overconfident, they're impulsive, they've lost that filter to kind of make that decisions of what is appropriate and what is not. Insomnia because of all of that excessive energy, and irritability. Okay, one of the drugs that is used for mania is lithium. It's a very successful drug. It's used sometimes on its own, sometimes in combination with anticonvulsant medications. The only thing is that although it's been successful, we don't know how it works. Okay, so lithium has been used for over 50 years to treat mania. And I'm guessing, researchers are like, okay, it works, we'll move on to something else. It's not studied. How does it work? Now, psychoactive substances. So we talked about, these changes in consciousness due to diseases. What about psychoactive substances? So these recreational drugs that we take in order to deliberately change the mood, in order to deliberately change our state of consciousness, and maybe even eliciting hallucinations and such. So virtually all of the psychoactive substances that we take are going to alter the biogenic amines, dopamine and serotonin pathways. For instance, cocaine. Okay, cocaine will block the reuptake of dopamine in the presynaptic axon terminal, which means that there is going to be a lot of dopamine in the synapse. And remember, when we had lots of dopamine, what did that do to us? Well, we had that elevated mood, that mania, okay, going on. There was the impulsiveness. Okay, so that is all, these are all symptoms of kind of what cocaine would do to the person. Now, tolerance, and we talked about tolerance before, but tolerance, one more time, is the need to increase the dose of the substance that is being taken because the patient or the person has now, in order to get that same effect they were getting at a smaller dose, they would have to get a bigger dose. Okay, so increasing the dose of the substance are required to achieve the same effects that the person was getting in response to those smaller doses that we start off with. There is also cross tolerance. So if two different drugs work the same way, if they use the same neurotransmitter or the same receptors, we could develop cross tolerance between them. Okay, now tolerance can develop. Remember when we said how to get rid of a neurotransmitter? We had different ways of doing that. So to get rid of a neurotransmitter, just kind of a refresher, we would either reuptake it through the presynaptic neuron or break it down using an enzyme, or it could diffuse away, or the cell could protect itself by downregulating the receptors. Now, tolerance can develop as a result of these. Okay, tolerance can develop because of the downregulation of the receptors. So now I need a bigger dose to stimulate now these less receptors. Or it could be because the drug changed the activity of the enzyme that is involved in the neurosynthesis or in the degradation of that neurotransmitter. Or the drug that I'm taking changed the reuptake of the neurotransmitter. So tolerance develops because I have changed the way my synapses are dealing with the neurotransmitter in one way or another. Now, if the patient or the person stops that drug and they start to go through symptoms, these symptoms can either be physiological or psychological symptoms. That is known as withdrawal. So when it's hard to get rid of a drug, that means that the person is abusing the drug. They have went into these withdrawal symptoms, and that is a sign of substance use disorders. Substance use disorders could be anywhere from alcohol, tobacco, cannabis, opioids, and stimulants like cocaine and amphetamines. Even caffeine is considered a substance abuse disorder. Okay, all of these disorders are going to act on the mesolimbic and the mesocortical dopamine pathways. So dopamine is considered the major neurotransmitter in substance use disorders, but there have been other neurotransmitters involved. For example, GABA, enkephalin, serotonin, and glutamic acid. But by far, the one that has been pinpointed as the main cause of the substance use disorders would be the neurotransmitter dopamine. These are the diagnostic criteria for substance use disorders. So you'll ask yourself or your patient a bunch of questions. And if they answered yes to 2 or 3 of them, that means they have a mild disorder. Yes to 4 or 5, that would be a moderate disorder. 6 or more yeses, that means that they have a severe substance use disorder. And I asked myself these in regards to coffee, and I did answer, in fact, about 3 of these yes. So I do have a mild substance use disorder when it comes to caffeine. Okay, so for example, and these are, kind of like the main points. So impaired control, meaning that you have been using it for a longer period of time than you wanted to. So your intention was to maybe try to just try off 1 cigarette. Okay, but you never intended to smoke, but now you're using it for a longer period of time than what you actually intended it to be. So that could be, an evidence of substance use disorder for tobacco, for example. You want to get rid of it, you want to stop it, but you're not successful in doing so. You're spending more time thinking about it and trying to get it. There are cravings involved if you cannot use it. Okay, so these are all signs of impaired control. Social impairment, meaning that you are now going to do things that are not socially, that will affect your social obligations, might affect your work, might affect school, might affect your family, things that you would have not, you wouldn't cause these problems have you not needed to take these medications or these drugs. Okay. Risky use of the substance. So we're taking these substances, although we know the risks of taking them. Maybe we're using syringes that we know that are infected, yet we still use them. So we are putting ourselves at these risks, knowing the harms. Physiological indicators of adaptation, meaning that how do I know that my body has developed that abuse? That would be by trying to stop it. But if I do, I will start developing withdrawal symptoms. Those could be anywhere from, mild to severe headaches. It could go all the way to convulsions and even death. So these physiological indicators of adaptation would be due to these withdrawal symptoms that we will develop if we do not get that drug into our bodies. Okay. Now I'm going to stop right here, and I will see you in the next and last part of the chapter.